So I told you guys that there were 3 PARP inhibitors. Olaparib, which is approved under accelerated approval. Solo 2 trial, which is a maintenance trial, has been announced to be positive. We haven't seen the data.
Right.
Talked about Rucaparib, which also is a phase 2, submitted for accelerated approval, PDUFA date February 23rd. But this idea of maintenance, which is an FDA, which is an EMA approved in Europe for Olaparib, is something we really like. And in Niraparib, now the 3rd PARP inhibitor, we finally have a phase 3 maintenance trial that's positive and published in the New England Journal. Tell us about it. It's called NOVA.
Right, that's right. It's a NOVA trial. It was over 500 patients, and they really were evaluating patients who had platinum-sensitive disease that were treated with chemotherapy, at least 4 cycles, and had either a complete response or a partial response. So it's truly a maintenance trial, as you discussed. And they evaluated them in 2 cohorts, patients who had a germline mutation in BRCA and patients who had a non-germline mutation in BRCA were the 2 cohorts. But then they had the test, which is the MyChoice HRD test.
Myriad.
Mm-hmm. And so then they evaluated these 3 different groups, and actually they drilled down even more. But in the manuscript, it's basically these 3 different groups. And across the board, the maintenance Niraparib approach resulted in improved progression-free survival in all 3 groups, whether they had a germline mutation in BRCA, and the numbers there are pretty impressive. It was 22 months in the group that was treated with Niraparib versus about 5 months in
I just need to
those
enjoy
that got
that.
placebo.
Think of that. 22 months PFS versus 5.
Mm-hmm.
Well, I know you're a hazard ratio guy, and the
Okay.
hazard ratio was 0.27. So, you know,
Oh. That's not as good
reduction.
as the study 19 with Olaparib, which is 0.18. Does
Yeah.
that mean Niraparib is not as good a drug? Because
I'm not even
I'm a
gonna
cross-trial
go there, Brad.
comparison guy.
I'm not even going to go there. I'm going to move
And
on.
so that was a
So-
phase 2 in Olaparib, but it's not fair to compare the
And
maintenance.
it's a phase 3
This is
trial.
a phase 3, thank you.
I think regardless, they work. PARP inhibitors work in this setting
work
to
good.
prevent disease progression. The next group was
22
the
versus
group
5
that had
months.
they did not have a germline mutation in BRCA, but they had a positive HRD test. And in that group, you had about a 9-month difference in progression-free survival. So it was 12.9 months for the group that got Niraparib, and it was 3.8 months for the group that was treated with placebo. And hazard ratio here was 0.38.
Great.
So about 60% reduction. Now let's look at the last group. The last group was non-germline BRCA mutation, and this group had about a 6-month improvement. It was 9.3 months with the Niraparib treatment versus 3.9 months. Hazard ratio there was 0.45. So, you know, here we've gone from the situation where I was thinking we would be directed more toward precision medicine, personalized care approach, where we use biomarkers to determine who's going to benefit from therapy at all. Now we're in a situation where maybe everybody benefits, but we can determine who's going to get the highest magnitude of benefit if they have the biomarker. I want to go back. Can I go back
Yeah,
1 second? Because I
this
think
is
it's important.
excellent.
If you read this paper, dive into the supplementary appendix,
Mm-hmm.
because in the appendix, they'll break down that group that has a non-germline BRCA mutation, but they're HRD positive. When I first saw this data, I thought, well, the somatic patients, the patients who have the somatic tumor mutation are going to be the ones driving this hazard ratio. But actually, it was beneficial in both the group that had the somatic mutations as well as the group that was germline, somatic mutation negative, but HRD positive, which was a pleasant surprise for me personally.
And in reality, this is what we would have expected to see, I think, given what we already know from Olaparib and what we've seen actually in the Rucaparib, is that HRD patient population, you know, specifically if they have disease left after platinum induction therapy, which we know half the patients in that study did have, then I think that's what we're essentially seeing is response rates to resident disease.
So let me put a different spin on it. It works great in the germline BRCA. It works pretty well in the HRD positive. But even without the test, it still works. And even in the HRD negative, it still has a hazard ratio of about 0.7 and a 3-month PFS. So is there really
No. The hazard ratio in the
0.58.
HRD negative group was 0.45.
Okay, all right.
It's 0.58.
Oh, maybe if you drill down to just that
Yeah.
negative group.
Yeah, just the
supplement.
negative.
You do
Yeah.
germline negative.
Oh, yeah, you're right.
HRD
Non-germline
negative.
negative, HRD negative, you're right.
So
0.56.
Still
.6,
really good.
0.6 with about a difference in the
But
median
still,
of 3.
40% reduction.
Yes.
Yeah.
Absolutely.
So do we need the HRD test? That's what I'm trying to get at.
I think you do.
The numbers are less
You
important.
know, I think you do because I think what we're all recognizing is that personalized therapy or precision medicine isn't just about the biomarker to direct therapy, but it's also discussing with patients toxicities and quality of life issue. And so this way, when you use the test, I can say this is the benefit that you're going to receive from the drug in the context of here's the side effects.
What do you think, Tom?
And see what the value is for the patient.
Because it's going to work. It has a chance of working either way, but with the information, you can have a more confidence that it's going to work.
There's two ways of looking at it. One is Niraparib is very, very effective in all comers, and the magnitude of effect rivals that of any chemotherapy that you would see in that setting, so you could argue not to have the test. On the other hand, I agree with Anjali's in the sense that we have multiple therapies coming online and a number of therapies to choose from now, and when you're looking at a difference of 3.1 months versus the profound differences that you saw of 17 months and you know, some of the other ones, you have to balance that. Right. And having that information, in my opinion, would be helpful. The question is, how much is that going to cost to get that information, and how does that fit into the whole rubric of how we're going to spend our healthcare resources?